Hi, my name is Larry Weisenthal. Today we're going to be discussing colorectal cancer. I'd like to start with a couple of case reports. The first case was a 61-year-old male, former Ford Motor Company heavy truck engineer. In 1974, please note the date, he noted, quote, black stools. He went to his primary care MD, who did a rectal exam, which tested positive for occult blood from the material on the gloved finger. The patient then underwent what was then a brand new procedure called fiber optic colonoscopy. Multiple polyps were encountered and excised. Thereafter, continuing to age 87, he had repeated colonoscopies every 3 to 5 years. On almost every exam, he had polyps which were excised. After age 87, which is when he had his last colonoscopy, he stopped having these examinations. At age 90, he underwent an 80% gastrectomy for gastric adenocarcinoma. The same year, also at age 90, he underwent a 4-vessel coronary artery bypass graft procedure. 11 and a half years later, at age 101 years and 7 months, he finally died. No post-mortem exam was performed. The lecture correlate is the ability of so-called screening colonoscopies to serve as therapy to remove premalignant polyps before they turn nasty. The patient, incidentally, was my father. Patient number 2 was a very recent case of mine. I run an esoteric cancer laboratory, and my laboratory received an ascites specimen from Modesto, California. This was about 3.5 weeks ago. This was a specimen from a 33-year-old construction worker. He was the father of 3. His chief complaint was initially, at the time he first presented for evaluation, his chief complaint was episodic abdominal cramping. He, quote, never had this before. Physical examination was reportedly unremarkable. Notably, a rectal examination was not performed. Laboratory studies were normal. Hemoglobin was low normal. Subsequently, he was lost to follow-up. He ultimately presented with major problems, including malignant ascites. The ascites tested positive for adenocarcinoma. Markers were consistent with a colorectal primary. Patient received chemotherapy with a standard regimen called FOLFOX, 5-FU, oxaliplatin, leucovorin. Unfortunately, this had minimal positive impact, and he died just very recently on January 10th, 2023. This is a real-life case, and the rhetorical question is, would a stool guaiac from material on a gloved finger have been positive at the time of his chief complaint? We'll never know because it wasn't performed. In any event, the lecture correlate is colorectal cancer is increasingly being diagnosed in shockingly young people, such as this 33-year-old patient. Proceeding. I've got a lot of slides, and some of them are very busy, and I'm going to have to hurry through them. I think that most of the slides have important material on them, and we can take advantage of the digital format that people who are interested can either stop or screenshot the slides and look at them in greater detail if I hurry through them too fast. In any event, starting out, colorectal cancer. It's the 3rd most common neoplasm worldwide. Breast cancer just this year edged out lung cancer for number 1. It's the 2nd leading cause of cancer deaths in the United States, so it's a very important cancer, and as I noted, it's happening increasingly in young people. There's 151,000 new cases diagnosed in the United States last year and about 53,000 deaths. With regard to trends, colorectal cancer incidence is declining by 3.7% per year among older adults, but the incidence rates are increasing by 1.8% per year in adults 54 years and younger. And we're seeing increasingly cases of patients in their 30s and even an occasional patient in their 20s. No one has any idea why this is occurring. With regard to etiology, both inherited susceptibility and environmental or lifestyle factors play a role. Adenomatous polyps are precursor of most colorectal cancers, and measures that reduce the incidence and prevalence of adenomas may result in a subsequent decrease in the risk of colorectal cancer. There's a predictable defined sequence of progression from normal colonic epithelium to frank carcinoma. And in this slide, it shows that the steps are first normal colon epithelium transitions to a hyperproliferative epithelium, and this can then progress to an adenoma, typically a polyp, and then to a carcinoma. And even once the carcinoma forms, there are additional changes, which are accumulation of genetic abnormalities, which typically result in a progression to a more aggressive phenotype. There are a number of defined genetic mutations which occur in this process, and these consist of both frank gene mutations and also epigenetic changes such as DNA methylation, and these are shown in this slide. The most important of these is so-called KRAS mutation. Now, KRAS is a gene that signals proliferation versus differentiation. In other words, with normal KRAS function, the epithelial cells differentiate into mature epithelial cells which have a benign function doing what they're supposed to do. However, in the case of a KRAS mutation, you can get a mutation such that the cell does not differentiate but remains in a state of proliferation, abnormal proliferation. And this occurs in about 1/3 to a little bit more than half of colorectal cancers. So roughly 32% to 57% of colorectal cancers are associated with this defined KRAS mutation. What about inheritance? Well, most cases of colorectal cancer are so-called sporadic. That means there's no antecedent known familial history. In about 10 to 30%, depending on the study, in about 10 to 30% of cases occur in patients who have a prior family history of colorectal cancer, but the family is not a member of a defined syndrome. Now, there are some well-described colorectal cancer inherited syndromes. Most important of these is probably Lynch syndrome, which comprises about 2 to 3% of all colorectal cancers. We'll be discussing this in greater detail momentarily. About 1% of cases are familial adenomatous polyposis, and smaller percentage are hamartomatous polyposis syndromes, and then there are even more rare conditions. Now, the lifetime risk of colon cancer in a first-degree relative of a so-called sporadic individual is increased by 2 to 4-fold. So if you have a positive family history of colorectal cancer, you've got a 2 to 4 times greater chance of getting colorectal cancer yourself. A wide variety of genes have been identified which confer this increased risk, some of which were described on the preceding slide, and environmental or lifestyle factors may also play a role. Now, a very important form of mutation in colorectal cancer involve so-called microsatellites. Now, microsatellites are short tandem repeats or simple sequence repeats, and these are shown in the left-hand side of the left-hand cartoon as these little red areas, little red bars in the coiled DNA molecule. And so scattered throughout the DNA, you've got these so-called microsatellites or short tandem repeats. And the important factor of these is that they have a very high mutation rate. Now, if the mutations occur in a non-coding region, which most of them do, it really has no clinical impact. However, if these mutations occur in a coding region, this can lead to genetic disorders. Now, most of the time when you have a damaged area in DNA, these are repaired through an excision repair process. So it's very, very common to get DNA mutations. You go out and do a little bit of sunbathing, you probably have thousands of mutations in your epidermal epithelium. But most of these are repaired without any problem. But the trouble is that sometimes some people have so-called deficient mismatch repair, or so-called microsatellite instability. In other words, what this is an inability to repair these mutations occurring in microsatellites, in these microsatellite areas of DNA. So deficient mismatch repair is also known as microsatellite instability, and these are essentially equivalent terms. DMMR and MSI mean about the same thing, and this is very, very important in colorectal cancer. And all colorectal cancers should be screened for either DMMR or MSI. And there's several ways of approaching this: PCR tests, or else next generation sequencing, DNA sequencing, and there's a couple of newer methods of doing this. But there's a number of available clinical tests to screen for either DMMR or MSI, and all colorectal cancers should be screened for this. About 20% of tumors with DMMR will have germline DMMR, and this can produce Lynch syndrome, which was one of the hereditary colorectal cancer syndromes shown a couple slides ago. This is of clinical importance, not simply because it may be a marker for Lynch syndrome, but in the 80% of DMMR tumors which are not associated with Lynch syndrome, it still has clinical importance in that if patients that have DMMR tumors should not be treated with chemotherapy, but may have beneficial effects of immunotherapy. So it's important both for being a marker for possible Lynch syndrome, which has implications with regard to screening relatives of the index case, but also for treating the index case, choice of therapy, that it would be chemotherapy versus immunotherapy. And those who have this DMMR should be treated with immunotherapy rather than chemotherapy. Here's just an example of a Lynch syndrome pedigree. It's autosomal dominant inheritance with incomplete penetrance. And you can look this over if you're interested in inherited pedigrees. Now, one of the other inherited colon cancer syndromes is something called familial adenomatous polyposis, formerly called Gardner's syndrome. This is also autosomal dominant inheritance. The mutations occur in the adenomatous polyposis coli, APC tumor suppressor gene. And these patients, I'm sure you've heard, have from an early age multiple that is tends to scores of polyps. And if these patients are not given a therapeutic intervention, either colectomy or very aggressive polypectomy, they'll virtually all develop colorectal cancer. Now I said that there's a variety of these inherited syndromes with defined mutations, and this is a very busy slide which just shows some of these. Familial adenomatous polyposis and Lynch syndrome we've discussed, and there's a number of others, and you can pause this lecture and look at the slide at your leisure, or screenshot it or something like that. Now, what about prevention? Well, there's a number of things that you can do if you're worried about colorectal cancer, which you should be. I'm worried about colorectal cancer. I still am. After all, even though I'm a rather elderly citizen, my father did live to be almost 102, so I still observe lifestyle interventions to reduce my risk of colorectal cancer as well as other problems. So avoiding alcohol and tobacco, losing extra weight, eating more fruits and vegetables, avoiding fatty foods, taking in more calcium, and low-dose aspirin. Now, low-dose aspirin is kind of controversial. There have been many studies done on low-dose aspirin with regard to protection against both cardiovascular disease, but also colorectal cancer. Personally, in reviewing the literature, I think the preponderance of evidence does strongly indicate that low-dose aspirin could be of benefit in reducing risk of colorectal cancer. And this could be by two mechanisms. One is, since frank colorectal cancer bleeds often, it may have an even greater propensity to bleeding if you're taking low-dose aspirin. So it may lead to earlier diagnosis if you're on low-dose aspirin. And then there's some theory that it may actually serve as a suppressor of carcinogenesis, although this is not entirely clear. And as I just want to, being totally honest, the evidence that low-dose aspirin it can reduce mortality from colorectal cancer is not universally accepted, although I believe it's true. Now, this is another very busy but very important slide. And what this shows is that there are a variety of methods that can be used to screen for colorectal cancer. And I'm sure that most of you at this stage are well aware of all of these, so I'm not going to go through and read this slide. What the slide shows is the various types of screening interventions, and I'll briefly run through these. So fecal occult blood testing, which is guaiac-based, fecal occult blood testing through immunochemical methods, so-called Cologuard test, flexible sigmoidoscopy, digital rectal exam, and colonoscopy. And shown on this slide are, first of all, the evidence that shows that these screening interventions yield positive results, and some of them are well studied with randomized controlled trials, others with simple case-controlled studies and cohort observational studies and so forth. You can look this over. And these screening modalities can have impacts on both colorectal cancer incidence and colorectal cancer mortality. And I'm just going to look at the top line test just to give you an example. So fecal occult blood testing has been studied in a number of randomized controlled trials. It does not have an effect, a demonstrable impact on colorectal cancer incidence, or if it does have an effect, it's very small. And when you think about it logically, you would only expect any of these interventions to have an impact on incidence if you can diagnose not simply cancer, but polyps. So the reality is that although some polyps do bleed, such as my father at age 61, most do not. So if the polyps don't bleed, then you're not going to diagnose them with stool guaiac testing, stool occult blood testing. But colorectal cancer does bleed, and so you can diagnose colorectal cancer in an earlier stage by doing occult blood testing. And so that's just an example of these various screening interventions. And if you can just look at this slide on your own, I think it's important. I mean, some of it may actually serve as a board question, so look it over. And just as a brief aside, I'm sort of recording this, obviously. I'm looking through a kind of a PowerPoint presentation, and I've got distractions such as my cell phone going off, and I've got traffic in the background, and I got stuff, so I occasionally get distracted, so please make allowances for that. Anyway, so this is quite important. So American College of Physicians colorectal cancer screening guidelines. I think this is a very high probability board question. So the American College of Physicians in November of 2019, which is their last update, had the following recommendations. Firstly, average risk adults, that is, adults without a positive family history of colorectal cancer or one of these other hereditary syndromes. So average risk adults should be screened between ages of 50 and 75 years of age. In other words, starting at age 50, ending at the last colonoscopy at age 75. Now, having said that, these were ACP guidelines as of November 2019. Now, since then, a number of entities which provide screening recommendations, most notably the American College of Gastroenterology, now recommend beginning screening at age 45 rather than age 50. And the reason why they're recommending screening at an earlier age is, as I mentioned before, colorectal cancer is increasingly being seen in younger and younger people, so it makes sense to start screening earlier and earlier. With regard to which of the methods that is used to screen, clinicians should discuss harms and benefits with the patients and make a decision. And on the next slide, I'm going to go through what the testing, what acceptable screening modalities are. Now, the recommendation is that screening be stopped at age 75 or in patients who have a life expectancy of less than 10 years. I am a great believer in individualizing both therapy and screening. And so there are people that are 75 that are very old people, and there are people that are 75 that are very young people. And I do think that, like in my particular case, I intend to keep screening myself, as long as I'm healthy, for a really long time. And so if I'm 80 and feeling, like I'll live another 10 years, I'll get another colonoscopy and so forth. And I think you can apply the same sort of common sense reasoning to your own patients. Now, what are the testing recommendations? So you've got a choice, and these are the things that should be discussed with patients when formulating a screening plan. So either you can do every 2 years fecal immunochemical testing. In other words, every 2 years do a Cologuard testing. Or every 2 years do high sensitivity guaiac-based testing, fetal occult blood testing. Or every 10 years do colonoscopy. Or every 10 years flexible sigmoidoscopy, plus every 2-year fecal immunochemical testing. I think this is quite important to know these. So these are, if you're taking care of patients and they reach the age of 45 and they're of average risk, you ought to tell them that it's time to start on one of these colorectal screening programs. And you go through each of these and you and the patient can make the choice. Now, just to cover a few more things, in addition to the instrument colonoscopy, there's such a thing as computed tomography, CT, or so-called virtual colonoscopy. And this is something that's pretty good. The advantage is you don't need to do an instrument colonoscopy, which is arguably less unpleasant for the patient. although the patient still has to undergo the bowel prep, and you know, it, I'm not sure that it's all that much, but much more benign than doing just a regular colonoscopy. But in any event, it is an option. It's not as sensitive and it's not as specific as colonoscopy, but it's pretty good. Moving on to the biology of colorectal cancer, most of them are adenocarcinomas. Smaller numbers are signet ring adenocarcinomas. Wait, I said that wrong, and I'm not going to start from the beginning, so I'm just going to correct it right now. So you've got adenocarcinomas, you've got serous tumors, and you've got neuroendocrine carcinomas. Of the adenocarcinomas, those are two subtypes, either mucinous or signet ring types. The serous tumors are those that have a little bit of some connective tissue associated with it. Neuroendocrine tumors are important because their prognosis is worse than pure adenocarcinomas. Moving on to start discussing staging, TMN definitions. A T1 lesion is confined to the mucosa, hasn't involved the basement membrane, so it's the mucosal epithelium. That's a T1. T2 invades through the basement membrane into the smooth muscle. T3 invades out to the serosa but not through the serosa, and T4 goes through the serosa. Now, with respect to the nodes in the M, an N0 is no lymph nodes positive, N1 is 1 to 3 lymph nodes positive, N2 is 4 or more lymph nodes positive. With regard to the M classification, M0 is no Mets and M1 is metastases are present. So having covered TMN, we can now move on to staging. So there's a typical stage 1, 2, 3, 4, also called Dukes A, B, C, D. And in stage 1 tumor, it's invaded through several layers of the bowel but has not spread outside the wall. Stage 2, cancer has grown through the muscle layer of the bowel or rectum and invaded nearby tissue but has not spread to the lymph nodes. Stage 3, cancer has spread to the lymph nodes, and stage 4 is metastatic disease. So repeating, stage 1, the tumor is inside the colon and hasn't invaded through the colon wall. Stage 2, it's invaded through the colon wall to the surrounding tissue, but no lymph nodes. Stage 3, lymph nodes positive. And stage 4, metastatic disease. I'm going to skip through this one because it's redundant. You can pause it and look at it, but it basically shows you the same thing as the previous slide. Now, this is important, location-specific behavior. The left or distal side is a narrower bowel lumen, and the stool is more formed. So it's more likely that you're going to get bowel obstruction symptoms. And this usually results in an earlier diagnosis, and so the prognosis for left-sided tumors is better than for right-sided tumors. Now, the problem with right-sided tumors is you've got a wider lumen and you've got a more liquid stool, so it's less likely to produce obstructive symptoms. So a more common mechanism for diagnosis is occult bleeding, which can be either anemia or blood in the stool or other associated symptoms, and this has a worse prognosis. Now it may be also that biologically the right-sided tumors are a little bit more aggressive. It's not clear, but in any event, what is clear is that the left-sided tumors have a considerably better prognosis than right-sided tumors, probably mainly because of earlier diagnosis. Now, how do we go about treating colorectal cancer? And this is another busy slide, but I'm going to spend a little bit of time on this. I'm going to kind of go through this stage by stage. So stage 0 and stage 1 tumors, stage 0, by the way, is going to be strictly confined to the epithelium, not going through the basement membrane. Stage 1 might have gone through the basement membrane, but it still hasn't gone through the bowel wall. So both stage 0 and stage 1 are strictly treated with surgical resection, no other adjuvant therapy. Now stage 2 is different for rectal and colon. So rectal cancers and colon cancers are different with regard to stage 2. Now I'm going to start with rectal first. So all stage 2 rectal cancer patients, and so once again, stage 2 is when you've got invasion through the bowel wall, but no lymph nodes. Now the problem with rectal tumors is that oftentimes the surgery requires removal of the anal sphincter, which is pretty morbid, and you'd like to avoid that if you could. So what is always done is prior to surgery, both radiotherapy and chemotherapy are given. And so what you hope for is a complete remission. So if you get a complete response, disappearance of all tumor, these patients don't have to undergo surgery. So instead, they're just followed very closely, and some of them may never need surgery. Now, in the case of colon cancer, these are not treated with radiotherapy. And but they may get chemotherapy as an adjuvant if they're high risk. And what is a high risk tumor? Well, if you look over on the right in that kind of green box, a high risk stage 2 tumor would have one or more of the following. First, microsatellite instability, which we discussed. A T4 tumor, which is a really large tumor. Bad histology. Bad histology just means poorly differentiated tumors, and they typically behave more aggressively. Lymphatic invasion, microscopic lymphatics, not the lymph nodes, but the lymphatic vessels. But so in other words, these would not be true stage 3s because the lymph nodes aren't positive, but you can see cancer cells in the lymphatic vessels. Or else if you can see in the small capillaries, vascular invasion. Or else if after surgery the CEA remains elevated, then these people are at high risk of recurrence and they would get adjuvant chemotherapy. And then moving on to stage 3, it's the same for both rectal cancer and colon cancer, and typically stage 3 patients are going to get both surgery with adjuvant chemotherapy. And stage 4 are treated with chemotherapy or other procedures, which we're going to discuss. With regard to the surgery, the surgeons have their choice of different ways of lopping out the tumor, and you can kind of look this over, and it just depends on where the tumor is, what they have to do. Now, how do you follow patients that have been treated with primary surgical resection and possibly with adjuvant radiotherapy and or chemotherapy? So every 6 months, the patients get a history physical and a CEA level for 5 years. Every 12 months, in addition to the Q6-month H&P, every 12 months they get a CT of the chest, abdomen, and pelvis for 5 years. And the reason for that is that if you can diagnose an isolated metastasis, a so-called oligometastatic disease, that is, metastatic disease not being present at primary diagnosis, but down the road they develop a metastasis. And if it's just 1 or 2 sites of metastases, these may be treated with local measures, usually surgical resection, and you can actually get a cure. So it's important to screen for oligometastatic disease, and you do that with CT scanning. PET scans you don't do, and so CT scans you do, but PET scans are not indicated in colorectal cancer either preoperatively or postoperatively with regard to screening. These patients also get colonoscopies periodically for 5 years, and then every 5 years thereafter. And again, surgical resection of isolated oligometastatic disease can be curative. Now, when colorectal cancer metastasizes, the most common location, most common site of distant metastases is the liver. And that's because of the portal circulation. So the tumor cells get filtered through the liver and often deposited there. So the liver is far and away the most common site of metastatic disease in colorectal cancer. Now, the importance of this is that it can actually be treated, and even with liver metastases from colorectal cancer, you can get a cure if the metastatic disease can be resected. And if it can't be resected, then as a second choice, there's other things you can do to try to destroy it. I'm going to go through it in the next couple of slides through these. So the treatment of choice is surgical resection. If there's recurrence in the liver, if it's possible to resect it, even by doing a total lobectomy in the liver, you go ahead and do that because you can cure those patients, and the best chance of cure is with surgical resection. If you can't resect it, like let's say that there's just too many or it's in different areas of the tumor, let's say you've got 3 or 4 locations and it's in all areas of the liver, so you obviously can't remove the whole liver. So what you can try to do is to ablate the isolated metastases, and you can do ablations on multiple metastases. And there's a variety of methods that can be used to do this, and those are going to be discussed in the next few slides. If you can't ablate the individual lesions, then you can treat a large region of the liver with hepatic arterial chemotherapy. So in other words, interventional radiologists will put in a catheter into a hepatic arterial that supplies the area of involved liver in question, and then chemotherapy can be infused through the catheter, and so the tumor is exposed to very high doses of chemotherapy, and this can be very effective. Another method is so-called chemoembolization, where you're actually embolizing the blood vessel, the arterial, and this blocks the blood supply, and hopefully you get downstream partial or complete tumor necrosis. And finally, there's occasional indication for local radiotherapy for these liver metastases. Now, once again, resection offers the greatest likelihood of cure for patients with liver-isolated colorectal cancer. 5-year survival rates after resection range from about 25 to more than 50%. So that's pretty good, averaging 40%. So you can get prolonged survival, hopeful cures, if you can resect all of these areas of metastatic disease. And surgical mortality is from doing this is pretty low, less than 5%. Now, if you can't resect the tumors completely, then you can ablate them. And one way is with cryoablation. And what you do there is put a probe right into the area of the tumor, and then you put liquid nitrogen through the probe, and you kind of create this white snowball. And when you do that, that freezes the tumor, and then when you thaw it, the tumor cells lyse because when you freeze water it expands, it breaks the cell membranes, and then the tumor cells then die. So that's one method, is cryoablation. Another is thermal ablation, and this is more commonly used, radiofrequency ablation. And what you're basically doing is putting in a probe and putting in microwave energy. So you're kind of microwaving the tumor, heating it up, and you get coagulative necrosis. And this, so you can treat multiple liver metastases with either cryoablation or thermal ablation. Now, with regard to metastatic colorectal cancer, we're actually making progress. So these are patients with stage 4 metastatic disease. And back in the 1980s, when either these patients were managed with best supportive care or very kind of non-aggressive single-agent chemotherapy, usually just giving 5-FU, you got a median survival of only on the order of 6 months. But with more aggressive 5-FU, like 5-FU combined with leukaphorin given in higher doses, given in infusion schedules, rather than just as bolus low-dose therapy, the median survival increased from 6 months up to nearly 12 months. And then with the addition of other agents beyond 5-FU, either oxaliplatin, and that's the so-called FOLFOX regimen, or irinotecan, the so-called FOLFIRI regimen. Now our median survival is up over 18 months. And then we get monoclonal antibodies, and these are bevacizumab, which we'll be discussing shortly, and cetuximab. But so with chemotherapy plus monoclonal antibodies, now we're getting close to 2 years of survival. And then with individualized monoclonal antibody therapy, we're now up over 2 years median survival treating colorectal cancer. And some of these patients have very gratifyingly long remissions. Now, so how do we personalize the therapy? Well, so again, the antibody therapies we have are two types. One are so-called anti-EGFR assays. So these are antibodies that bind to EGFR receptors on the tumor cell membranes. And when these antibodies bind to the EGFR receptors, either they will directly induce apoptosis, or else the fact that you have these kind of foreign antibodies that are binding to the tumor cells, this can serve as a marker for attack by the immune system, by T lymphocytes. Can be marked for destruction. But so the two anti-EGFR antibodies are cetuximab and panitumumab. Now, therapy with these antibodies can be individualized, because what you do is you do testing for specific genetic mutations. And if the patients have either a KRAS mutation or a BRAF mutation or an NRAS mutations, any of these three mutations, they typically will not benefit from this therapy. So patients that have these particular mutations should not receive therapy with these agents, but should get something else which is more likely to work. The other thing is that these, besides the molecular markers, these treatments, for whatever reason, only work on the left-sided or distal tumors. And that's one of the things, one of the several reasons why the distal tumors have a better prognosis than the proximal tumors. Now, the other type of monoclonal antibody therapy for colorectal cancer are those that target VEGF, vascular endothelial growth factor. Now, VEGF is, you can think of it as a fertilizer for tumor cells. So it's actually a survival factor. Normal adult endothelium doesn't need VEGF to survive. But tumor capillaries are kind of like fetal capillaries in that they do require VEGF to not only proliferate, but also in most cases to survive. So if you can block VEGF, you can not only prevent the capillaries from growing, but you can actually cause involution of the capillaries. So when the capillaries disintegrate, then the tumor doesn't have a blood supply, and the tumor will die also. So you can actually get not just cessation of growth of the tumor, but you can get shrinkage of the tumor, and sometimes dramatic shrinkage of the tumor by interfering with VEGF. And the two molecules that can do that, one is bevacizumab or Avastin. Bevacizumab works by directly, sorry, my computer's going off. Bevacizumab works by directly binding to VEGF and removing VEGF from the bloodstream, and so then there's no more endothelial fertilizer, so the endothelial cells die, the capillaries disintegrate, and then the tumor dies, hopefully. Ramucirumab works a little differently. It actually binds to the VEGF receptor, so it blocks VEGF from attaching to the receptor, but the result is the same. If the endothelial cells don't have their VEGF, then they die, and then the capillaries die also. Now, it would be nice if we could combine these monoclonal antibodies, if we could combine EGFR antibodies with VEGF antibodies. Unfortunately, that doesn't work, and in fact, if you combine them, patients do worse than when treated with either alone. Now, so we talked about chemotherapy and then monoclonal antibody therapy, but there's also immunotherapy, and this is with checkpoint inhibitors such as pembrolizumab, nivolumab, ipilimumab. And the patients that will respond to these are the ones that have the microsatellite instability, otherwise known as DMMR. deficient mismatch repair, or microsatellite instability. Again, these are kind of synonymous terms, but about 2 to 4% of colorectal cancer patients have this DMMR or MSI phenotype, and these patients should not be treated with chemotherapy, but they may have considerable benefit from immunotherapy with the checkpoint inhibitors. Now, how are we doing with regard to treating colorectal cancer? Well, not too bad. It's unlike pancreatic cancer or glioblastoma. We actually, as a result of the treatments that I've just described, patients can do pretty well. So patients with stage 1 disease, you've got a 99% cure rate essentially. Stage 2 disease, this is where it can even invade outside of the colon, but it doesn't go to the lymph nodes. Even with these large lesions, the patients can have 89% long-term survival. Even with lymph nodes, that's stage 3 disease, that's 71% 5-year survival. And with stage 4 disease, even with metastatic disease, 13% of these patients can enjoy a longer survival. Now, there's some interesting trends with regard to mortality, both by state and by country. And I find these data really quite fascinating. So this compares the colorectal cancer mortality in 2 states, Mississippi and Massachusetts, over a almost 50-year period. So back in 1968 or so, right around 1970, 50 years ago, there was a higher mortality in Massachusetts than in Mississippi. And perhaps back then, the residents of Massachusetts, they had access to, a lot more filet mignons and high quality beef, and they probably did a lot more drinking and so forth. And in the ensuing years, over 50 years, the mortality rate in Massachusetts has fallen dramatically. And some of this, I'm sure, is lifestyle improvements among residents of Massachusetts. But some of it is also quality of health care, in particular, screening colonoscopies and the like. So you're getting fewer tumors and you're getting earlier diagnosis of tumors in Massachusetts, but not in Mississippi. Now, what I think is even more interesting is comparing the United States and Canada. Now, we think of Canada as having this very sophisticated healthcare systems, universal healthcare, and the demographics of Canadians is pretty similar to the demographics of Americans. Yet, now we're talking, this graph doesn't show mortality, but shows incidence trends. So how many cases of colorectal cancer are being diagnosed? And what you see in the United States is that this is going down rather precipitously and encouragingly, whereas in Canada, not so much. And what I think is really happening here, I mean, you can make up your own mind, but what I really think is happening is that there's considerably greater financial reward for when gastroenterologists in the United States do colonoscopy than their counterparts in Canada. And so there's kind of a financial incentive for doing a lot of colonoscopies and polyp resections. So you might say that the greed of American gastroenterologists is paying off with regard to the patients. And personally, I'm all for having colonoscopies. I've had 3 of them so far, and I'm going to continue having them. And I strongly recommend that when you get to be an elderly physician like I am, that you'll be having them regularly too, as long as you remain healthy. Because again, they cause, colonoscopies not just give you earlier diagnosis of colorectal cancer, but actually prevent colorectal cancer. Now, finishing up, the first case report I told you was my father, and I want to make a point on this. So these are photos of my father at age 101 with the love of his life, and he had screening colonoscopies through age 90. At age 90, he had an 80% gastrectomy for gastric cancer and also a 4-vessel cabbage. And you might say, why do all of this aggressive stuff on a 90-year-old? Well, he lived another 11 and a half years, and this is, I believe strongly in treating the protoplasm, not treating the calendar. So there's a chronoage and there's a bioage, and I think the bioage is very important. Last thing I want to say, in sense, colonoscopy is so important with regard to preventing colorectal cancer. What's really important is what gastroenterologist you refer your patient to for colonoscopy. And this is a something that takes technical skill, and colonoscopists have vastly different proficiencies. And the way that you can gauge the proficiency of a colonoscopist is by what's called the ADR, or adenoma detection rate. So if you do hundreds of colonoscopies, you should be identifying polyps in 40% of your cases. And actually, really good colonoscopists will identify polyps in 50% of the cases. So polyps are very common. And if a good colonoscopist is in screening is picking up polyps in 50% of his cases, and that shows how common polyps are. And since these are definite premalignant lesions, you want to be able to find these polyps and take them out. So the average adenoma detection rate in the United States is now up to 40%. And personally, if I was having a colonoscopy, I'd want to have an endoscopist that had a detection rate that was above average. So you don't want to refer these to people that do few colonoscopies and have a low detection rate. You'd really like to do good by your patients and find a good endoscopist who has a very high detection rate of adenomas. Anyway, that's the end of my lecture. Thanks for putting up with my various technical glitches. Good luck on the boards.